Hello, my name is Amber Bugno, and today I'm going to do a presentation on non-invasive genetic prenatal testing. Non-invasive prenatal genetic testing is testing that's done where you do not have to puncture the body. So this could be through maternal blood or an age-assessed risk. Why is it important? This is important because all pregnancies are at risk to have a chromosome abnormality. So anyone who wants to start a family or whose family wants to start a family, there's a risk with every single pregnancy. Since the 1970s, non-invasive genetic testing has been routinely offered. Now, in the 1970s, it was maternal age. And they decided that if you were above the age of 35, that you were at increased risk. Chromosome abnormalities are a deviation of the number or a deviation in the structure of those chromosomes. And with a chromosome abnormality, the associated disabilities could be mental or physical. And the American College of Obstetrics and Gynecology recommends that every single woman who is pregnant be offered some form of genetic testing. Chromosomes in a human normally there are 46, and they're paired with 23 pairs. The most common anomaly is a trisomy, and this means that there is a third copy of a specific chromosome. The most common trisomies are trisomy 21, which is Down syndrome, trisomy 13, which is Plateau syndrome, trisomy 18, which is Edwards syndrome. Now, it is thought that the defect happens because there's a deviation in the cell division when the fetus is forming, and this could be due to maternal exposures or maternal age. It hasn't actually been pinpointed why. It just can. Now, to understand the non-invasive tests, you have to understand the epidemiologic terms that go along with the test. Detection rate is the ability to detect whether the disease is present or not present. And this is based off of the specificity and the sensitivity of the testing. Now, to have a high sensitivity, you have to have a high ability to detect the disease. This would give a low false negative rate. To have a high specificity, you have to have a high ability to detect whether that the disease is not present, and this would give you a low false positive rate. The first case of Down syndrome was suspected in 1950. That's the first time that anyone actually described someone that had Down syndrome. And this is the most common chromosome abnormalities. Again, in the 1970s, based on maternal age, any woman above 35 was offered invasive testing. So if you went to the office and you were 35 or older, there was an increased risk to having a child with Down syndrome. Now, the increased risk is based on the actual having a child with Down syndrome or the capability of losing the pregnancy due to the invasive testing procedures. So depending on what the invasive testing procedure was, you could have a 1 in 400 chance of losing the pregnancy, a 1 in 250 chance. So they based it off of the age 35, where your risk was 1 in 385 to have a child with Down syndrome, or 1 in 192 to have any other chromosome abnormalities. Now, as the woman got older, that chance increased. So someone at the maternal age of 40 had a risk of 1 in 106 to have a child with Down syndrome and 1 in 66 to have a child with any other structural defect. In the 1980s, they started testing maternal blood. So they took going from just the maternal age to actually testing the blood. And the first test was called the double test. It tested two different hormones, the alpha-fetoprotein, which is the AFP, and that's a protein that's found in a growing fetus, and the total HCG, or the total human chorionic gonadotrophin, which is a hormone that's just produced in the pregnancy in general. This had a detection rate of 63%. The next test was the triple screen, which in that test, they tested the estrol levels, which is a hormone that's made from the placenta, along with the AFP and the HCG. The triple test had a detection rate for Down syndrome of 70%, and a detection rate of trisomy 18 at 78%, but it was a very poor test to have for trisomy 13. The next test was the quadruple screen or the quad screen. This tested the AFP, the HCG, the estrol level, and an inhibin A, which was made from the placenta. The detection rate for trisomy 21 was 75%. The detection rate for trisomy 18 was 78%, but again, a very poor test for trisomy 13. Then came along ultrasound, and ultrasound has advanced over in the last 30 years, amazingly. In 1985, Dr. Benacerraf concluded that if a child or a fetus had a thickened nuchal fold, that it was at an increased risk for trisomy 21. As they did for more investigations into the 1990s, trisomy 21 became associated with heart defects, short fetal limbs, and brain abnormalities. The nuchal fold was the first soft marker that they saw. And this marker, these two images are the fetus of the same gestational age, which is important because as baby gets bigger, these things get bigger. So these are the same gestational age. And this is a normal nuchal fold. So the back of baby's brain, and then this is the skin thickness. Now, over here, this is the skin thickness. And anything over 6 is considered abnormal. Brain abnormalities. Fetal ventriculomegaly, again, a big one. So this, again, 2 fetus of the same gestation. This is the normal measurement, which is below 10. And then this is an abnormal measurement, which is 40. So if you were to see one of these, you would suspect some type of chromosome abnormality. Now, ultrasound for trisomy 18, it had soft markers for, the soft markers for trisomy 18 were heart defects, choroid plexus cysts, overlapping digits, or clenched hands. So again, you can see normal brain tissue here. It's nice and white. And then if you look over here, there's that dark circle right there. That's a cyst. So that would say, there may be something going on, a minor marker. Here you have the overlapping clenched hands. And then here you have the nice open hand. Now for trisomy 13, these structures are major structures in the face and in the brain. So if there's a suspected, if you suspect that there is an intracranial defect, a huge one, or a huge facial defect, trisomy 13 is what you suspect. Now for the facial defects and the brain defects, these could include full-of-prosencephaly, a proboscis, or facial clefts, like a cleft lip or a cleft palate. Again, if you look at the picture here, you can see that baby has like a little slit in the lip. And here, this is a proboscis. You can see it just coming right off the forehead. Now, in the 2000s, they discovered that a nuchal translucency, or measuring the back of baby's neck, could give you an 80% detection rate for Down syndrome or chromosome abnormalities. Of course, this is with the 5% false positive rate. When you added maternal labs, so when you tested mom's blood with it for 2 different hormones, which is the PAP-A and the free beta HCG, the detection rate went from 80 to 90, but it kept the false positive rate of 5%. And this is the nuchal translucency. So first trimester, these are both fetus that are about the same age in gestation. This is the nuchal fold that's normal, and then this is the nuchal fold that's abnormal. So any nuchal fold that was seen that was above 3 was considered abnormal and was sent on for further testing. Since the 1950s, they've noticed that there are fetal cells in mom's blood. But it wasn't until 2011 when Sequenom was the pioneer in actually isolating these cells, diagnosing the trisomies, and what they've termed it as, it's the non-invasive prenatal genetic testing. That's actually what it's called, or what everyone calls it in the medical field is the NIPPET testing. There are two ways to do this. You can do a targeted sequence, which specifically targets those chromosomes. So chromosome number 21, number 18, number 13. Now, it's a smaller sample and it only tests those chromosomes. Or there's a massive parallel shotgun sequencing, and that takes a massive portion of cells. It tests all of the chromosomes and analyzes all of them, but it takes a little bit longer, and then the detection rate kind of fluctuates a little bit. Now, again, depending on the lab, depending on which type of sequencing they're doing, there is a detection rate between 98.6 and 100%, with a false positive rate of 0.3% and 0%. I mean, again, based on labs. Now, the only people that insurance is covering and are actually offered this NIPT testing is for the high-risk population, as of right now. So this is your advanced maternal age, which would be anybody above 35, someone who had a previous child that was affected by chromosome abnormalities, or if they had an abnormal screening, so an earlier abnormal screening and then the NIPT test and then invasive testing. There are pros and cons to testing. You know, any type of genetic testing has a pro and a con. A lot of the cons are basically because of the feeling that you would terminate the pregnancy or not terminate pregnancy. It doesn't change my opinion. It wouldn't change the way, you know, I was pregnant. However, what people don't realize is if you have the prenatal non-invasive genetic testing, it can involve or advance to other testing, which could prepare you for the delivery, and whether a specialist needed to be available for that delivery. There are hospitals that cannot accommodate fetus that have defects, and you know, you could be in trouble if you delivered at a site that couldn't handle that type of chromosome abnormality. You know, in conclusion, the non-invasive testing that started back in the 1970s has advanced dramatically in the last 30 years. Testing went from the maternal age to now is in the fetal cells that are found in maternal blood. It's amazing. The technology is just absolutely amazing. And again, remember, ACOG recommends that all pregnancies, all pregnant women be offered some form of genetic testing. The advances have come with high detection rates, low false positive rates, and hopefully one day all of the non-invasive testing can replace the invasive testing completely and therefore take out the risk of losing the pregnancy due to any type of genetic testing. So, thank you.